Case Management in Healthcare by Selena Troop. Hello, my name is Selena Troop. Welcome to my page. I have been working as a case manager myself since the beginning of this year. I have been a registered nurse since 2010. No, since 2019. I was an LPN since 2010. So, working as a case manager has kind of shown me the need for this aspect. Case management programs have been around a super long time, since as early as the 1800s, which I was completely unaware of until I started doing some research. Case managers help patients, healthcare professionals, doctors, nurses, therapists, a little bit of everybody, as well as from my aspect, I work for insurance company. I work for Aetna, so I handle it on my end. It is not a one size fits all. Some patients need help with transportation. Some patients need help finding a place to live or paying medications, paying utility bills. So depending on what their individual need is what I help them with, or I put in if it's something that a social worker could help with, or if they're having behavioral health issues, I put in a behavioral health case manager. So it all just depends on the individual um, services. So if I call a member and they're living in their car, I send them to social work to try and see if they could get them on a waiting list for some type of housing. Exploring different research avenues can prove or disprove whether case management has an impact on the patient outcomes or the rehospitalization rates. And I will present this information throughout my PowerPoint. Working as a case manager has definitely shed some light on the benefits of this program as well as the shortcomings. Quick research suggests that case management services do reduce healthcare costs and improve patient satisfaction. Unfortunately, we still got a long way to go. There still are a huge gap in available resources, especially in certain areas of the state. I cover Georgia, and the program I cover is called a DSNP, DSNP, which stands for Dual Special Needs Program, which you have to have Medicare as well as some form of Medicaid to be on this program. And since I cover Georgia, all of my members we call them members and not patients, members that I see live in the state of Georgia. And just like every aspect of nursing, there are still very many patients that are non-compliant, no matter how many times you tell them. There's a huge unmet need, and this unmet need is housing. By the year 2035, there will be 24 million people over the age of 80. I have noticed many of these patients or members are still living alone. They still have very limited incomes, limited mobility, and most often suffer from one or more chronic health conditions. The shortage of available housing and affordable housing to the elderly is outrageous. There are waiting lists for anything considering senior housing, very long waiting lists. Over 10 million households headed by someone over 65 pays more than 1/3 of their income just on rent, and more than half of them pay more than 50% of their rent. I recently came across one of our members who is living in what seems to be an unlicensed group home, who has an income of $1,100 a month, who was homeless and now is living in this little group home type setting, and they're charging her $1,000 a month, and that does not include her food, anything like that. So I had to get social work involved because this scenario seemed really sketchy and it just didn't set right with me. So I got social work involved in the situation to see if there was any help that we could do to possibly get her out of this situation. When you have a very limited income, a lot of them cut back on food and medications just because they need to afford their rent. So many will skip picking up medications because they can't afford to, or they're not eating like they're supposed to just because they can't afford to. As a case manager, we do try our best to assist patients with getting suitable housing, getting on waiting lists for suitable housing, help come up with different resources available to help pay for medications, pay utility bills, anything like that. Case management services are becoming more and more cost effective due to decreasing the number of emergency room visits, Also, case managers, especially in an acute setting, will help reassure the patients with anxiety that they're not alone and they're there to help, and they can, help them at discharge to go home to maybe a better environment. PICO question that I had chosen. In the elderly population, how does the use of case management services compare to those who did not receive each service impact rehospitalization? So the elderly population, as I stated earlier, would be those over age 65. This population is generally known for rehospitalization within 30 days after a hospital stay. While reducing this rehospitalization rate will be difficult, it's not impossible. Case management programs are implemented in all different domains, including education, social work, mental health. My setting was insurance, compensation, as well as a variety of different healthcare settings. Search strategy and results. I started at the South College Library and came up with 16,701 articles that have been published since 2019. I went through and picked out ones that included my specific criteria that I was looking for, and I came up with 5 of those articles that I really thought were good to use in my Synthesis 2 paper. I also looked up through Google scholarly articles about the effect of case management services. After 2019, I came up with 176 articles that technically fit the criteria. Pulled out articles that were all about COVID because there was many, many, many. And I looked through the rest of them and I ended up coming up with more than 10 that I could use for my Synthesis 2 paper. Synthesis of literature. Case management services are about helping patients, helping them navigate through healthcare. It's hard. It's hard to navigate. It's hard to understand. And case managements are there to kind of help them get through what they need to. A chart review of patients was done between 2015 and 2017, and they compared those involved in case management to those who are not, and it proved that the readmission rate significantly decreased for those using case management services. So those using case management services only had an 18.4% readmission rate within 30 days, and those who were not involved in case management had a 52.6 readmission rate within 30 days. So all the articles pretty much explored the fact that case management does have benefits to the potential overall outcome of patients. Case managers are always working towards the positive outcome. You have to gain their trust first, because I get hung up on a lot. People don't understand why I'm calling. They think I'm spam. They don't need me. If I can get them to stay on the phone for less than 60 seconds, I can explain some basic things that I can offer them, and they're more willing to stay on the phone. Some of them still say, nope, I don't need you. They hang up. But many of them are like, they start thinking about all the things they could benefit from. Especially a lot of the things I can offer them are free. And they don't even realize that they have these benefits until I call and explain it to them. So definitely getting them on board. Some of these older physicians don't really use case management services. They're very set in their ways, but little over, time, people are starting to be less resistant to change. The setting for change. Most research has proven that using case management services is effective in having a positive outcome. Being able to have case management who can help every single person that needs it. There needs to be a ratio, especially in acute care facilities. If you could hold hundreds of people, you need to figure out how the caseload would factor for a case manager. If a case manager can help 30 people, then you need to figure out how many case managers you need to have on staff for this specific facility. From an insurance aspect, it's completely different. My caseload is 600 members, but the ones that are considered low acuity, I touch base with them once a year. Unless they have a hospital stay, they need something sooner. They're all given my direct number. They can call me and leave messages if they need something, if they need help, which is why I have the ability to have such a large caseload. If I had a caseload of mostly high acuity, I would maybe have 200 or 300, because you have to touch base with them at least every 3 months for high acuity, and medium acuity is every 6 months. So it just depends on what their acuity is as to what your caseload looks like from an insurance aspect. In an acute facility or in a SNF or a rehab or something like that, those ratios are completely different. So some of the plan changes. Using the ARC model to implement the much needed changes, using evidence-based practice, I think there should be some type of a universal database for case managers, social workers, things like that. So it could be via your geographical location. It could be via the state. I think definitely the state at the largest, but something that includes housing resources in a specific area, food banks, churches that help, or nonprofits that help people pay utility bills or pay for medications. There are always people out there willing to help. You just need to know the information. With more available resources, case managers can definitely help more people. Unfortunately, there are always still barriers. Funding is a big thing. But in acute care settings and things like that, if they could, from the very beginning, budget in all of these case managers that need, it would definitely help in the long run. Readmission rates definitely look bad on a facility. I know when I worked in home health, they used to, call us to complain if a patient was readmitted. Well, we have a specific criteria when we did home health that we had to send patients back to the hospital if they met certain criteria. So it definitely does not look good on a hospital if they keep having all these 30-day readmissions. So if we were to decrease the 30-day readmissions, the hospitals would be happy because it would affect their overall star ratings, as well as from an insurance company aspect because it costs less money to keep people out of the hospital. So the evaluation. So periodically around the year, I think a research team needs to reevaluate the effectiveness of all these case management programs. They need to reevaluate the readmission rate. That could be done pretty much on a yearly basis, just looking at the overall numbers, just to see year to year how they are decreasing. I think patient satisfaction should be reassessed and evaluated quarterly, because I feel like if patients are not satisfied, we need to know sooner than later. Making sure that resources that case managers have available are up to date. Sometimes people run out of funding. Meals on Wheels was really good for so long, but I know in my specific area, they have no money, so they can only help a small amount of people, and they have a very long waiting list. So making sure whatever database that houses all this information is always updated to show where to call or who's out of funding and things like that, so you're not wasting time calling people that cannot help. Even throughout the year, speaking to the nurses, the physicians, all the providers, everybody in the hospital, just to check on the overall compliance, morale, and satisfaction of the patients, and following up with them once they get home to make sure that they're doing what they're supposed to do. Following up on discharged patients to make sure that they're taking their meds, they're going to their doctors, they're being compliant, they have food, they're eating well, especially for those that CHF are eating low sodium, diabetics aren't, eating a lot of starches and sugars. In conclusion, the elderly population are really who needs the resources the most to stay healthy and remain out of the hospital and decrease on emergency room visits. There are many elements involved in case management, such as advocacy, assessment, planning, implementation, monitoring, education, counseling, and community service development. So, assessing a patient's needs, coming up with a plan, implementing this plan, and giving the patient all of the resources you have available. Being in different settings, making sure that patients are following up with their doctors. They might say they are. We can call the doctor's office, and the doctor's office can say no, they haven't seen us in 2 years. So definitely making sure everybody's communicating together. The number one thing in case management is care planning, making sure that they have a roadmap, what we're going to follow, what we're going to do, what our end goal is to make sure that we accomplish our end goal. I hope you understood, I talk fast, what my project is about, and I hope you have a wonderful day.